Very. Our first webinar.
Yes. Well, we did have a little introductory one,
Yep.
but our first official webinar. So hi,
Great.
everyone. Yeah. Maybe Omar, you and I can introduce ourselves and then we can get started. So this is our first webinar. We're hoping we'll get into some of the basics, like, what is equity? Why is it important in equity and guidelines? Why do we want to consider equity in guidelines, and how do we do so? I'm Andrea Darzi. I'm an assistant professor at McMaster University, jointly in the departments of anesthesia and health research methods, evidence, and impact. I wear two hats, being a methodologist with a big passion and focus in guideline development and adaptation in low resource settings, and equity integration into guideline processes and implementation tools. And another big passion of mine is chronic pain and chronic conditions, and trying to translate all of those methods and knowledge into that space to ensure more trustworthy guidelines. Omar?
Thank you, Andrea. So my name is Omar Dewidar. Andrea and myself have co-founded the GIN Equity Working Group, and we're the current co-chairs. I'm a research associate at the Bria Health Research Institute at the University of Ottawa. Um, I also lead the Grade Equity Work Project Group, and Andrea and I also co-lead one of the objectives of the Cochrane Thematic Equity Group, specifically focused on implementation tools and guidelines. And I am based in Toronto because I am at the end of my medical training, and we'll see what happens next. So,
All
yeah,
great things, I'm sure.
great.
Hey.
So, yeah.
So I do want to take a minute to just acknowledge that I do work at McMaster, and it's located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. I'm very lucky to be able to work on these lands, and do the work that I do. So these are our disclosures. I am also the assistant director of the National Pain Center. I think Omar covered a lot of um, our positions around equity and guidelines, and I did previously hold the role of assistant director of the American University of Beirut Grade Center, where we did a lot of work around adaptation, and equity and guidelines and an adaptation of guidelines. So today we're going to be covering what is health equity, identifying populations experiencing inequities, principles or the foundational principles for equity and guidelines, and then health equity in the evidence decision process. And in the first half of this presentation, I'll be covering the first three and then handing it over to Omar to walk us through current guidance on how to integrate health equity in the evidence decision process. So we're talking about what is health equity or inequity. But for a moment, I want us to really just forget about the term and think about what actually matters and what does it stand for. And in the most basic and lay terms, I would say we want to understand what are the problems we are facing, who is we, so who are facing these problems, what aspects of the problem can be solved, and how. So when I think of it that way, it becomes so much easier to digest these two definitions and see the differences in these definitions. So inequality and inequity are used really interchangeably by many people, but the reality is that they're not one and the same. So WHO defined in 2012 health inequalities as differences in health status or in the distribution of health determinants between different population groups. So what this is saying, and going back to how I started this, is what are the problems, what are the differences, and who are the groups that are facing these differences? But it does not really consider whether the differences in health outcomes are avoidable or unavoidable, whether they're acceptable or not. So it doesn't give us room to understand what is something we can solve versus not. When we think of health inequity, it adds a moral and ethical dimension to it. And it really looks into reasons for these differences and identifies the people um, experiencing these differences and better understanding whether we can solve them. Are they avoidable or not? Are they unfair and unjust? And should we be addressing them? And how should we be addressing them so that we don't result in a population being socially disadvantaged? So really, this is at the essence of it, and Whitehead in 1992 defined it quite nicely. Next. So before we really consider and judge equity, we need to know which populations are affected and in what contexts. And I think Progress Plus really helps us do that. So it's really asking ourselves all of these questions to address in different situations, in different conditions, in different diseases. What are the things that we need to think about? What are the factors that are relevant to this specific topic and may influence health outcomes? So going through them quickly, there's place of residence. So where does someone live? Whether they live in an urban or rural setting, if they live in a specific region, and how that may influence their health outcomes. Race, ethnicity, culture, or language. These are characteristics that may affect your experience with the healthcare system. And this could be because of systematic or systemic biases or language barriers. Occupation, whether you're experiencing unemployment or informal employment, unsafe working conditions, you may not be covered by insurance for certain things, and that may affect your access to certain healthcare services. Gender and sex, so differences in health outcomes or healthcare access that's related to either gender or biological sex. Religion, you may have certain religious beliefs or affiliations that might influence health behaviors or the way you can interact with healthcare services. Education is the same. So having the health literacy that might influence your access or your ability to advocate for yourself or to be able to receive certain health services. Same for socioeconomic status and social capital, right? Where the quality of social relationships or networks that you have that could really affect how you access resources. Then you have the additional factors, which are the plus of Progress Plus. And those are the personal characteristics associated with discrimination, like age and certain inabilities. Features of relationships, like you have smoking parents, or you're experiencing certain stigma or shame at school or exclusion that might influence your health outcomes. And then time-dependent relationships. So situations that put you temporarily at a disadvantage, like leaving a hospital or respite care. So it's really important that we identify these populations before we start talking about how to consider and judge equity. Next. Now, recognizing what the condition or problem is and understanding what are the factors that are relevant to that, now we need to start thinking about in exploring the foundational principles that go into this assessment. So what are the principles that you should carry with you in any guideline that you are doing and should be the foundation for any guideline development process, any adaptation process, any methodological framework or tool you are developing. And these principles really came from a triangulation of data sources. So looking at all of the handbooks out there, taking into account expert experience, expert knowledge, all of the literature, and really triangulating that data to come up with these 7 really founding principles. And these principles include both an equity, diversity, and inclusion lens and an explicit equity focus and research. And what do those 2 things mean? As many of you may know, EDI is when we're talking about representation. So it's this broader approach to ensure that we have full representation and full participation of all the groups that are relevant in a specific guideline process. And we're going to talk about that a little bit more later. But the next is equity focus. And this is where we're targeting specifically looking for information that addresses the health disparities that we've identified and should help us resolve this issue or try to achieve health fair treatment and outcomes for these groups. So what are these 7 principles? They look very obvious, but they are very, very important, and they're really going to guide this whole discussion. So first and foremost is defining equity. How are you defining it in your guideline process, and what are the goals for you and your guideline development team? Second is ensuring that we're not thinking about equity as an afterthought. When we do that, we end up with a lot of blind spots. And then we're not sure whether we've considered all of the appropriate considerations through every stage. And we cannot fully trust the final product and ensure that it has really truly considered all of equity appropriately, right? In a transparent and systematic way. So really thinking about equity from the start is so important and defining it. Then we talk about meaningful engagement. Many times when we think of, the progress plus factors, we feel like we understand them. But unless you've really lived through an experience, having been disadvantaged temporarily or permanently, we really don't understand what that means and how that really influences our health outcomes. So involving and meaningfully involving people that have that experience in this within your guideline process is so important. It brings such valuable information, and it helps us fill out gaps that we may identify in literature. So having their insights, having their experience, and having their input into scope, into prioritizing questions, into meaningful outcomes, patient important outcomes, into making sense of knowledge, that's so very important. Ensuring equity and evidence synthesis. So from our literature search, right? Identifying and addressing gaps in the evidence. And from other methods work that is being done, we know that sometimes we don't find enough information, right? If you're doing a systematic review, you look for studies, you say, well, we didn't find enough information on equity. But there are ways that you can fill those gaps, right? Either by doing interviews, focus groups, doing some form of survey. There's always ways that we can find knowledge out there and inform our process. And it's important that we start thinking about that from the beginning so that you have the resources to conduct that. Then you're taking all of these steps and you're developing equity-informed recommendations. And Omar's going to go into much more details around this, but it's important to recognize that you don't have to end up with explicit statements about particular groups to have done a good job. As long as you've been transparent in how you've considered equity throughout, you will end up with an equity-informed recommendation and one that people can trust and they recognize that it's applicable or not applicable to them. Then you have inclusive knowledge mobilization. If we have the guideline and we've done all the work, but it's not reaching the right people, especially in an age of AI, in an age where, we use the internet a lot, social media, things that most people have, but many people may not, is really important to consider. How do we reach these diverse groups, and especially the groups that are experiencing disadvantage or inequities? And then impact, evaluating whether the work we did actually is having an impact when implemented. And sometimes we think we've done a great job and we think we've done it right, and it may not have the impacts we wanted. It may be misinterpreted, or it may have been received in the wrong way. And it's really important that we identify that really quickly, identify how we can correct course and actually correct course. Next. So you may say, okay, well, we've heard this all before, but it is interesting to see at face value in a small example what that actually looks like. So I think an example is the recent Canadian Rheumatology Association guideline, where they were developing a guideline on the management of rheumatoid arthritis with disease-modifying anti-rheumatic drugs, or DMARD. And what they did is from the beginning, they asserted that all individuals living with rheumatoid arthritis should have early and equitable access to rheumatological care. They recognize that there's delays in access, and those delays in access could be associated with worse outcomes and could disproportionately affect groups at risk of inequities. So they made that so clear right from the start, and they were very deliberate in the fact that they were going to be considering equity throughout. So zooming in on a specific question that they had was for people that have rheumatoid arthritis, are on DMARDs, whether biologic or targeted synthetic, and they've really achieved remission or low disease activity, and they're in a sustained um, uh, it's sustained, right? So they've been in remission for a while, or they've been in low disease activity for a while. Should we be considering tapering, right? And why would we want to consider it if they've achieved their goal? It's because one, there's medication burden. There's side effects that maybe we could taper a little or completely stop, and they could still have a positive effect in terms of their health outcomes. And also there's cost. So lowering healthcare expenses is something to consider. So what they thought about is considering this question, what are the contextual factors and equity issues we really need to be focusing on? And the first one was, if we were to taper, we need to make sure that if it doesn't work, that patients have access to medication really quickly so that they can reestablish their health status, right? Bring them back up if it wasn't working out. Second, they needed to think, who are the people that may not have rapid access to rheumatological care to safely taper? And they thought of people in rural regions, right? So geographical isolation. They thought about groups that may experience systemic barriers, like indigenous communities. They thought about limited healthcare navigation by refugees and first generation immigrants. So we're thinking about language barriers, systemic biases, all of that, that may limit their ability to have rapid access. And then economic and housing instability among groups that may be of the lower socioeconomic status. Next. So it made them think that tapering may not be the best option for all. However, you still want shared decision making, and it's still up to the patient to decide whether that is the most suitable option for them or not. So they did an equity informed recommendation, and they made a conditional recommendation against tapering when rapid access to reestablished care is uncertain or challenging. It was conditional because certain people, despite this, may still want to taper, and there should be a shared decision making process. But their aim was to prioritize patient safety and equitable health outcomes. Some of you may think, was this the right approach? Did they do it right? Did they get it right, or did they get it wrong? That's not what we're looking at right now. But the idea is that they were very systematic and transparent in how they considered equity, and they allowed us to understand their thinking process and how they achieved that recommendation. And that in itself is very essential. Yes. So we have these founding principles, and now you've seen what the output could look like. And you'll say, well, how can I make sure that I'm thinking about all the right things and asking all the right questions at every stage of the guideline development process? And there are really great tools out there that have been developed. This one by our group and led by Omar, which is the equity extension checklist for the GIN McMaster checklist, which most of you probably know and use in your guideline processes. This allows us to really think systematically and transparently about how we can integrate health equity into guidelines. It covers all of the stages. It's applicable to different types of guidelines. And it turns these theoretical considerations it operationalizes them, right? It turns them into practical implementation. Now, you may say, there's so many checklists out there, and we have a little bit of checklist exhaustion. But the way I like to look at it is these tools and checklists, they allow us to change our habits in the way we are thinking and developing guidelines. The first time you do it and the second time you do it, it may be a little exhaustive. It may be a little burdensome because you are relearning how to think from the start and how to integrate equity from the beginning. But then it becomes a habit, the same way we do many other steps in guidelines, and you may not need to lean on it as heavily. So this is how we see the value of tools, or at least that's my perspective and from my experience. And it's important to change our habits so that we have better outcomes. Now, you go through the process and then you have to use all of this evidence and go through the evidence decision process. And this is where I'm going to hand it off to Omar, who's going to walk us through this guidance that really makes it much easier to digest and understand what does it mean to define, what does it mean to integrate, what does it mean to identify, and how do you end up with an output that you can trust. So Omar, over to you.
Thank you, Andrea. That was an excellent, I think, introduction to really the foundation that we hope to incorporate in everything that we do related to equity. But I think we could maybe just pause for a second, see if there are any questions. You've said a lot of amazing things, and people could be reflecting on them right now. Any burning questions?
Oh, Omar, just so that we don't forget, we will have two housekeeping issues at the end, an evaluation form, but also we want to send you a document that you could fill out in case you want to reach out to us or you want us to be able to reach out to you. We can't have access to your emails unless you allow it. So in case you don't have questions now, but we share with you the recording and then you have questions later and you want to reach out to us via email or want us to reach out to you with more resources, that will allow us to do that. Okay, and we'll put the links in the chat later on.
Great. Thanks, Andrea, for reminding us all. Um, I think it doesn't seem like there's something coming in right now, but as you said, they could come in later. We'll switch right now into looking at equity in the evidence decision process, which is more narrow focused, and from the context that I'm going to be talking about, it's very grade oriented. Because this is the updated grade guidance for considering health equity in the ETD framework. So I would imagine just by looking at the descriptions in the chat that most of you have heard of the grade ETD frameworks. So these are very nice criteria-based frameworks that list all the things that a guideline developer should think about when taking the evidence to formulate a recommendation or a final decision. And this is from the first version of the ETD frameworks in the BMJ, where you have all these criteria here on the left and how they would look like, or what are the signaling questions across different perspectives. And one of those, so just to go over them, you have priority of the problem. So is this problem that you're looking at very important? And why would that be from a baseline risk perspective or whatnot? Test accuracy of relevant benefits and harms. So how substantial are desirable and undesirable effects? You consider the certainty of evidence in the process, as well as the importance of the outcomes that you're looking at from a patient perspective. And then how do the benefits and harms with the certainty of evidence and outcome importance weigh against each other? And then there's other contextual factors that you would consider as well, including resource use, health equity, which was defined as what would be the impact of the decision on health equity, acceptability, and feasibility. So within the context of the grade evidence decision framework, you would need to have evidence on benefits and harms to develop your recommendation. That's the key criterion. And then everything else, that along with, of course, outcome importance and the certainty of evidence. But then everything under that, equity, acceptability, feasibility, resource use, these are contextual criteria that you would use to kind of complete the picture that you're trying to paint for the user. So one of the biggest challenges that people have been having since the development of the ETD is how do you answer that equity question? It says, what is the impact on health equity? There are these 4 signaling questions in the guidance that are supposedly there to help you answer that question, but that was really challenging. So the signaling questions were about, are there any disadvantaged populations? Are there any plausible reasons for differences between populations? Are there differences in baseline conditions across the groups? And then the 4th one is, are there important considerations for implementation? So the issue with these four is that there wasn't any guidance on how to answer these questions. One would be faced with these questions as soon as they look at the ETD, potentially after they've already looked for the evidence, and they would try to answer them and don't know how to do that. And so what we've done is we've been working on this for several years, did a lot of background work, including the work on the principles as well as the available guidance within grade and outside of grade to try to come up with a single streamlined approach that would help people answer that ETD question and help them draw meaningful conclusions. And the most important thing, as Andrea mentioned, was to try to come up with something that is systematic, an approach that's systematic, that would promote transparency and help develop evidence-based considerations. And so this new guidance highlights that you can't just start at the ETD. This really starts before that. And that's when you have the guideline question or when you're generating your guideline question. And so the bottom line behind this new guidance is that you should always seek the most rigorous evidence. And when that is not available, you can rely on expert evidence that would include lived experience of those who have the condition of interest. And from an empirical standpoint, you would apply what we call a health equity lens to the body of the evidence used to inform the decision. And I'll explain what that means. So with regards to health equity lens, that means process of seeking and synthesizing the evidence for populations at risk of inequities to guide the development of health equity considerations. What we don't talk about in this guidance is how do you weigh health equity relative to other criteria? That is something that is going to differ depending on the panel, on the context, depending on who's making the guideline and what is it made for. So health equity is contextual and will always be contextual until that changes. So now I'm going to go to the guidance. What we recommend doing at the beginning to help answer this question is you have to define the decision perspective and identify the populations that you want to focus on. So what we mean by decision perspective is there's so many different recommendations that could be produced, that could be developed from a clinical individual perspective, from a health systems perspective. Even more recently, we've brought in planetary health. And so depending on that perspective, your attention to health equity or the scope of health equity considerations will vary. A clinician who's focused on the individual patient in front of them would find it very hard to implement any equity consideration at the social or at the systems level. And so what we're starting with here in the guidance is help people hone their focus on whatever's relevant to the decision being made. And so if we look at the individual clinical perspective, we can draw on the example that Andrea talked about, which is tapering biologics. And the broader concept under that is that you would tend to focus on differences in baseline risks and what would affect the implementation of your intervention. Versus if you're developing a health systems recommendation, that is when you would want to focus on health equity consideration that addresses social and structural determinants of health equity. An example of that would be thinking about how that context would impact, for example, diabetes care for Indigenous populations here in Canada, which are disproportionately burdened and have very significant barriers to access. Now, once you have the perspective and how that would shape the health equity, your potential health equity focus, you need to think about what are the populations that I want to think about, that I want to address in this guideline. So I'm going to go back to Progress Plus. It's endorsed by Cochrane and so many other organizations, heavily cited since it came out, and has been very effective to help identify characteristics associated with inequities. Not all of these characteristics are going to be important. So the user should identify or be explicit on the rationale behind why each of those characteristics or others would be relevant to their condition that they're trying to address. The best way to do that is to also support that with evidence and also try to get engagement from different interest holders or stakeholders to inform this process. And again, one of the things that sometimes terrify people from engaging with health equity is the fear of not being inclusive enough. We acknowledge this as people who worked on health equity and people who developed this guidance, that you can't be comprehensive. Don't let the perfect be the bad of the enemy of the good. Do your best with the knowledge that you have and with the evidence that you have. And there's always room for improvement moving forward. So now, after the first step where you've thought about what is the perspective that I'm going to take, what are the populations that I am going to focus on, now you want to think about how am I going to integrate this concept of health equity into my guideline question. And that usually comes through the deciding, am I going to look at do I need a separate question for this population or for the purpose of advancing health equity? So as you know, we frame your guideline question as through the PICO framework most of the time. So would I need to split my question based off of the population, or are there any different values to the outcomes that would make me think about another question? And what we propose is that you always have to hypothesize a priori before seeking the evidence, whether this is needed or not. And I'll give you here an example on a cervical cancer screening guideline done by the European Commission, where they were looking at co-testing, so cytology with HPV testing versus HPV testing alone. And they wanted to think about health equity as well. So they thought about are there any factors that could basically influence the effectiveness or the implementation of this intervention. And although there are several, they made the decision that it wouldn't be significant enough or impactful enough that it would warrant a separate recommendation. So the key decision here is that we're going to go with a single PICO question, and we've already identified certain populations. It was like it included people with low SES and certain racialized groups as key populations that we want to focus on within this recommendation. And those would be population subgroups. We wouldn't try to develop a separate recommendation for them. But the most important thing is that you have to, once you come up with this hypothesis, you have to test it. When do you do that? When you start seeking the evidence. So in the evidence review process. And that would be the next step. And this step is where you seek the evidence and you assess the certainty in that body of evidence. And what we're saying in this guidance is there's several ways to do this. There's input from your interest holders or people with lived experience. There's a way that you could apply an equity lens to the evidence informing the net effect, which means the benefits and the harms, basically the mandatory body of evidence that you need to establish a recommendation. Or you could even expand this equity lens to look at equity considerations in contextual factors, like are there any differences among acceptability, feasibility, resource use, which often exists, but we all know that the ETD is used differently and depending on the resources. So what does an equity lens look like in practice? Basically, these 4 questions that are really focused, again, on benefits and harms, and each one of those questions would translate to something that would be meaningful when making the decision. So are there any differences in baseline risks? Are there any credible differences in effect? Are the priority populations that were pre-specified represented in the studies? And is there any evidence of feasibility or access issues? So Now that you have these four signaling questions, you can basically extract or seek these additional items when you're doing your evidence synthesis. And if we go back to the cervical cancer screening, when the equity lens was applied to the evidence, they found that there was no consistent, credible evidence that would suggest differences in effect between between the populations that they specified before. And so that confirmed, you know what, we will go with a single PICO question. There would be no a reason to come up with potential separate recommendations for the populations that we specified before. One of the questions, as I previously mentioned, includes looking at representation. So when you say that the representation could be, of course, easily judged if the population was explicitly excluded from the published report. You can tell that it wasn't there. And then the question is, do I believe that the effectiveness of the intervention to be completely different for these populations or not? But what if and there's smaller proportion of populations within these studies, or the studies include populations of interest, but we're not sure, are they truly represented or not, and what are the implications of that? And there's a very nice tool that you can use here. It's called the PPR. So we didn't invent this, it's been out for decades, but this is the first time it's been incorporated within the grade guidance and thinking about indirectness of the evidence. So basically, it's calculated by dividing the proportion of a subpopulation in the study by the proportion of the same subpopulation against all people with the condition of interest. So an example of that, if you're looking at a new medication for gout that had 8,000 people, 2,000 could be females and 6,000 are males. And if we say that the population level data shows that females constitute 23% to 27%, you can then calculate the participant prevalence ratio to be 0.93 to 1.09. And there's a rule of thumb saying anything between 0.8 and 1.2 would be well represented, above that overrepresentation and below that underrepresentation. But these numbers, again, are there to assist you. They're not absolutes. You should not be rating up and down, should not be rating down, my apologies, certainty of evidence based off of these numbers alone. There should be analytically decided. And here are the two reasons why you would basically rate down the certainty of evidence for indirectness. This is in accordance to the grade indirectness guidance. So if there's credible reasons to expect systematic differences, and if there's uncertainty in the baseline risk that would limit certainty in the estimates of the absolute effects. So now you've gathered your body of evidence. You've applied the equity lens. So you've looked at this, the lens in a way that to pull out evidence that could help you inform your equity judgment in the evidence to decision framework. Now it's time for you to actually make that judgment. And so we still have that signaling question. What is the impact on health equity? So what does that mean? That wasn't even defined previously. And so just to give people more context so they can answer that question properly, we've provided one. It is the extent to which a decision, if implemented as recommended, may affect the ability of individuals or populations experiencing a risk of inequity to achieve their full potential for health and well-being. So you want to keep that at the back of your mind when you're trying to answer that question and provide the judgment for the criterion. And so how would you assess this operationally now with the evidence? So as we said, at a minimum, you've applied the equity lens to the benefits and harms or desirable and undesirable body of evidence. Those four criteria actually, those signaling questions from the equity lens, they translate to different parts of the ETD criteria, so baseline risk, and if you looked at if you looked at effects, so relative and absolute effects, and the same thing with indirectness, all of those can be synthesized together to inform the impact on health equity. So you would look at those all together in combination to make that judgment. Is there any does health equity increase, or is it reduced, or is there no impact? Now, if you had the resources and the ability, and you already saw empirical evidence for other ETD criteria like cost effectiveness, acceptability, you can apply this equity lens to those questions. It wouldn't be those 4 questions that I showed you guys, but in the guidance, we have signaling questions that would align with those ETD criteria. Like, again, the ways for you to seek that information from the studies. And all of those collectively would impact your decision on health equity. And you can see how the more criteria that you seek, the more informed your judgment will be, and it could potentially even be your certainty would likely increase in that judgment. And to also now, I've shown you how to gather what evidence informs that judgment, but there's also some boundaries that we've tried to create for people, some guidance to help people make that judgment. So I've called these are the principles. So the first principle is if an effective intervention has limited accessibility, that is likely to reduce health equity. And we've seen that a lot in GLP-1, how it's a very effective intervention. Because of the high cost and access barriers, it will likely reduce health equity. If a intervention has greater absolute benefit in the priority populations, that will likely increase health equity. And we've seen that in an example where dental caries were more prevalent in immigrants. And so if an intervention is focused on addressing that, that would help. That it would yield greater absolute benefit, and that would likely increase health equity. And then the third principle that we came up with is health decisions that explicitly prioritize populations with the greatest unmet need are likely to increase health equity. So if you're coming up with an intervention that looks at housing support for those that are unstably housed, that would benefit them and would likely increase health equity. And then finally, and the most important one is if there is no empirical evidence, that does not mean that there is no impact on health equity. And we've seen this with an example here on chronic lower back pain, where there was no data on harms for spinal manipulative therapy, but the panel, based off their experience and clinical experience and also lived experience being involved on the panel, said that there's potential harms and with traction, and so this would reduce it. So now you've made the judgment on health equity. You've also made judgments across other ETD criteria. You're going to draw conclusions based off of this exercise and develop your recommendation. So this is step 5. It's very important now to consider, as Andrea highlighted, equity doesn't have to manifest itself within the recommendation. It could, and in that case, it could influence the direction and the strength, but it could also inform implementation strategies. So how you end up, you could come up with considerations or notes for the provider or the user to consider when applying or using this recommendation to help address inequities. The title here should be changed, but here are some examples of how this could manifest. So when options have similar effectiveness, health equity might become an important differentiating factor in selecting the preferred option. But also when an intervention is effective and may worsen health equity, like GLP-1, for example, that should not justify recommending against that intervention. Instead, the panel should focus on implementation strategies to help address these inequities. And of course, depending on the focus of the panel and the perspective of the panel, these implementation considerations will vary. Most important thing throughout this process is to document how health equity considerations have influenced the decision and how the panel came up with that final recommendation. So the take-home messages from what we've said today, combination of the 7 principles and the new grade guidance for ETD equity in the ETD, health equity is relevant to all guidelines. Now, the extent in which it manifests itself or how it looks within the guideline product varies. And the very important point about the 7 principles is that they are a list of evidence-based concepts that summarize how health equity should be considered in the guideline enterprise. We've used it to inform the development of the Jim McMaster checklist. We've used it to also inform the development of this grade guidance. And the grade guidance, the major contribution behind it is that people should make explicit and evidence-informed judgments about health equity, and this will likely lead to more impactful decisions that are equity-informed and improve patient health. So that's it for us today in terms of slides. Thank you so much for listening. We'd like to hear if you have any questions.
Oh, Omar, I guess it's important for us to tell them that we're hoping that another webinar would be specifically to kind of walk them through an example, like step by step, to kind of see how this guidance could be used from beginning to end.
Yeah, we were open to do that if that is of interest. I think there's a lot of things that we would like to share with you guys, get feedback, including equal, right, Andrea? So we'll see what people
From
think.
everyone. So, like,
Yeah.
I would love to hear about your experiences, your examples, the challenges that you've had. I think this is something we want this space to be bi-directional and to learn from you as well, right? A lot of you are working on really big guidelines and having these challenges, and we face these challenges every day. And maybe together we can come up with an even more exhaustive list of ways to work around limited evidence or innovative approaches to dealing with this, especially in contexts where it could be controversial, right? Specific terms or specific approaches. So I think there's a lot for us to learn in this room. And in terms of equal, yes. So when I talked about the example of the rheumatoid arthritis, I said we're not really here judging it, whether they really considered it every step and whether the output was trustworthy or not. But we are interested in that. That would be the natural next step. And we are right now developing a tool called Equal that is going to be integrated into EGRI 3, which is currently under development and is being endorsed by EGRI 3 and the EGRI collaboration. And the idea is to be able to assess whether equity is appropriately considered in the guideline process and whether we can trust the judgments and the considerations made. So we're hoping also to talk to you more about that and to user test it and get your involvement at different stages down the line.
Mhm. Yes, agreed, Andrea. And I'm happy to look at the comments in the chat as well and talk about them. But I actually, before that, we don't have a lot of time. So I wanted to ask everyone if you think that this guidance would help you with your guideline development processes. Is this new to you? Some of the reflections would be very helpful. And while you guys think about it, with regards to paucity of evidence, that is truly a challenge. And I'm not going to argue whether that is universally the case or not. What I've found from myself and others who have implemented this approach is that the evidence that we need to make the judgment could be there, but we weren't looking for it. And sometimes we try to hold the equity evidence to a standard that it might not be needed. So if you're trying to fish for these subgroup analyses to try to look for these differences, or trying to look at, let's say, extensive literature at assessing differences in values and preferences, that might not be there because it could be not have been done, or there actually could be, uh, or it could actually have very little impact, although it could be there on the decision. And so that's one of the things that we wanted to highlight with this guidance is the first part, if we can get people to start looking for the right things, and then with the absence of evidence, you can utilize lived experience. That lived experience could be collected using formal approaches like surveys within the panel, or some formal way of data collection uh, to try to minimize bias, and try to also collect the data in a way that wouldn't be overcome by some of the power dynamics within the panel. That could provide some, let's say, low certainty evidence, but things that could contextualize some of these decisions. Sanjay's saying the topic is not new, but explicitly informing the PICOs, the examples and ways to incorporate language into benefits and harms condition is very helpful. We've used surveys and focus groups, but finding participant proxies for pediatric conditions is a challenge. Oh, yes, I
Absolutely.
can, for sure, for
And
sure.
I wanted to say that we hopefully we're waiting for a paper to come out, but it's on limited evidence in general. It's not specific to equity, but I really do think, and as you said, that these topics are not new, and a lot of these challenges we face also with rare diseases, right, or with emerging diseases. So really, Omar talked about expert experience, not opinion, and through these methods of surveys and trying to minimize recall bias, all of that, but also databases. We should push in terms of future efforts that databases capture these variables, these equity variables, and make sure that we're capturing these individuals. How can we better get that information from people that are experiencing inequities, and make sure that these databases can actually provide us with this information? Because then, I mean, that's a very good way to get that information and quickly with minimal resources, as long as you have the right collaborations. And we need those networks set in place. So if we all have these networks, and we all have these connections, we can reach out to different groups that have these databases, tap into this evidence, and be able to use it to inform our guideline questions. Um, Obviously, there's more elaborate methods like doing retrospective cohorts or even prospective cohorts, right? But and I think we always worry, but there's never enough time, there's never enough budget. But if we start asking these questions early on and recognizing those needs, and we start asking for more budget, asking for more time, carving out space for these primary studies, or even doing them before we start our guidelines, I think we can start building that knowledge base. And yes, please, we know you get really busy once you're off this call. If you want to use the last 2 minutes to fill out the evaluation form, it really helps us in planning ahead how to conduct these webinars. You may say we want these to be more interactive. Let's sometimes have them, where we're presenting, but other times have like maybe hands-on experience. It will really help us shape the future of this group, because it's important that you're getting the most out of it. Yeah. And I did share before the form um, allowing us to contact you. I'll share it again. Let's see. Thank you all. This was great. I am excited to hear more from you probably next time.
Excellent. And Greg saying very helpful answering the equity question. ETD has at times been a challenge. I was reassured that some of the elements you described are things we've discussed in our guideline working groups of varying degrees, although not sure how consistent having more explicit guidance will help us make sure we're being consistent. Excellent. I'm very happy to hear that.
And
And
just make sure that we're transparent, right, in the judgments that we're making.
for sure. I really hope that this guidance, when it comes out, it really is useful and people feel that it's easily applicable um, to their context. Great. Okay. Well, we're at the hour. Thank you so much, everyone, for joining. And we're looking forward to staying in contact and for whatever's ahead. Thank you, Andrea.
Have a nice rest of the day or evening.